was basically a covering presentation. Brian Vasey is headlined to give this talk, and he was stuck. He actually asked us if we would give him permission to give this talk tomorrow, and I think probably at the end of this, we can make a decision about whether or not that's possible. The purpose of the presentation was to try and outline the basics of programming to see what differences there are, because most of us are doing Brady programming with single and dual chamber pacemakers, and to see what are the differences between single and dual chamber programming and CRT programming, uh, especially on the first visit. To look at ways to program a device to ensure that the device is giving you maximal efficacy, and then to talk briefly about optimization of device therapy. And maybe what I'll do today is cover 1 and 2, and then leave point number 3 for you guys to come back to on the 12th of March. Again, we talked about non-response in CRT last week, and we talked about two things. The absence of sufficient desynchrony so that you're not resynchronizing something because it's not desynchronous enough. And in order to address that, you need to be able to detect desynchrony. And the second thing is failure to resynchronize. And really, once you've put the LV lead in the correct place and you've closed up, lead placement is no longer part of the equation. So you only have two things. Either you're not capturing the device, in other words, the device isn't working sufficiently, or the timings in your resynchronization protocol are suboptimal. So to think about the programming, the focus of CRT programming is to ensure that CRT is delivered and meets the needs of an individual patient in such a way that a patient who might not be responding will derive more benefit. And there are two main priorities that I'd like to emphasize. The first one is to ensure that you are actually getting cardiac resynchronization. In other words, that you're capturing both ventricles at their appropriate timing. And the second thing is to optimize the timing between the atrioventricular delay timings and the ventricular to ventricular timings. And this will be something relatively new to those of you who haven't come across this and are focused on single and dual chamber pacing. Now remember, to promote CRT, that in bradycardia pacing, we want to minimize unnecessary pacing, allow the patient's own intrinsic activation sequence to take charge in bradycardia pacing, where you're trying to deal with heart blocks. However, with CRT, the reason you put the device is because you want them to pace using the CRT device. Ideally, 100% of the time. You do not trust the intrinsic activation sequence, which has significant delays, to deliver an efficient contraction. So the first thing you have to do when you're looking at a CRT device is verify that the patient is receiving continuous stimulation using the CRT device. In order to do this, you'll all be familiar with the standard interfaces of various devices, and you use a box called diagnostics in order to verify how much ventricular pacing is going on. And you can also check on certain key parameters to encourage maximum CRT pacing. And I'll talk you through those and probably close the lecture at that stage. So this is just an example of a interface. In a few weeks, we're going to invite all the manufacturers to give us a brief on the interfaces of their devices. This one happens to be a Biotronic interface. And if you can just have a look at this is a patient who's got a CRT device. If you look at the top, there's a variety of pieces of information that are actually being provided. If I can just get my pointer to appear red there. No, not yet. Laser pointer. Okay, so over here, as usual with all devices, you're going to have to test the atrial amplitude, the threshold, and the impedance, the right ventricular amplitude, threshold, and impedance. And again, make sure you test the left ventricular amplitude, threshold, and impedance. And you test it in the configuration of the pacemaker vector that the device is programmed at. You look at the battery, and you look at the programming modes to ensure that the mode, which is DDD, is also programmed not for RV pacing, but for biventricular pacing. You look at your parameters, a basic rate, etc., and you look to see how you've programmed the outputs in terms of the amplitude and the pulse width. And then here, the diagnostics, that gives you a lot of information. I know it doesn't project so well, but I zoomed in on it so that you could see over here. Diagnostics, pacing A, 19%. Pacing biventricular, 98%. And CRT, 99%. And then there's something called atrial arrhythmia burden. That's really important because if you're getting a lot of atrial fibrillation, then maybe you can't program the device to be capturing efficiently. In this particular case, the atrial arrhythmia burden was 0%. Some of the manufacturers recommend this system, which is essentially a standard system for looking at all pacemakers. You look at the patient's rhythm, their underlying rate, and the percent pacing. Just like we did earlier, we look at the battery status, the lead status. We check the sensing and threshold for each lead. We go to the observations or diagnostics box and see if anything has happened. In the previous patient, you'll have noticed there were 5 new episodes. So you would click on that and it would tell us what the device has noticed. And then finally, you'd make the adjustments, program and print the output. This is what they call the PBL stop method. Let me try and find. Then finally, and very briefly, after you've checked all of that, you then make sure that you're encouraging CRT by getting appropriate atrioventricular delay. Now, the AV delay is a time between the atrial beat and the corresponding ventricular paced event in CRT. If you push the AV delay too far out, say to 400 milliseconds, and the patient has a PR interval of 200, then by the time you're ready to pace a ventricle, the patient's own intrinsic device activation sequence has kicked in, and you won't have given the device any opportunity to do anything. So a long AV delay gives the ventricle too much opportunity to beat on its own. So the first thing to do is to make sure that you shorten the AV delay to something shorter than the patient's own intrinsic. So that's the other way to ensure that you're getting biventricular pacing. And this will probably be my final slide. Just a way of helping you understand biventricular pacing. This is my checklist. Every time I'm looking at a patient, particularly when they come for a checkup, I try and ensure maximal ventricular pacing is close to 100%. That means that you have to make sure that the patient's LV lead is capturing. The other thing is the pacing configuration guaranteeing LV lead capture? We talked about bipolar and quadrupolar leads last week, and different leads have different pacemaker vectors. And most of them nowadays will not allow you to pace the right ventricle inadvertently. But some of the older devices, especially the bipolar devices, have this configuration called, pseudo-bipolar, and you have LV tip to the RV ring. And sometimes you capture the RV ring believing that you've captured the LV tip. So when you're looking at the pacemaker vectors, make sure that you're not dealing with one of those parameters that will create a false reassurance that you're capturing the left ventricle. In general, left ventricular unipolar configurations, left ventricular configurations that go to the coil, like LV tip to coil, LV ring to coil, should be okay. But if it's sort of tip to ring, and the ring is in the right ventricle and the tip is in the left ventricle, you could be inadvertently pacing the right ventricle and making things worse. And then look for things that get in the way of your biventricular capture. So if the patient's got atrial fibrillation that's accelerating faster than the base rate, then that could be a problem. Or if the patient's getting frequent ventricular ectopic beats. And the treatments for these are obviously different. They're not programmable necessarily. If the patient has too much AF, sometimes you have to chemically or electrically ablate the atrial fibrillation. If the patient has lots of ventricular ectopic beats, Likewise, a chemical solution or an electrical solution may be necessary. Sometimes you're oversensing the ventricle. In other words, your device thinks that something's happened in the ventricle and it tells you we're not going to deliver CRT here. So you just have to check the sensing parameters against a sensed R wave and make sure that you don't have a problem there. And likewise with undersensing the atrium. And then I mentioned already the excessive atrioventricular intervals. And without further ado, I think that's 10 minutes. The final subject is the optimization of the delays. And just to give you a clue, the appropriate atrioventricular delays, the timing between when the atria is sensed or paced and when you then tell the CRT device to capture, forms this kind of shape for each individual patient. This is a cardiac output method for checking the atrioventricular interval to see which generates the best output. In most patients, the optimal and out-of-box setting is an atrioventricular delay of 120 to 130 milliseconds. But in some patients, that optimal delay is much higher, somewhere in the 190 milliseconds. And so it's important for us to understand that this sometimes changes a patient's output and outcome. And I want to stop there because it's 9 o'clock, and maybe invite one or two questions, but reassure everybody that we'll be coming back to this particular subject in a couple of weeks. There you go.
Thank you very much, Jeilan. That was very interesting, and thank you for taking over any defect in the program. That was very generous of you, and that was very giving. يعني فعلا I really appreciate what you did. It's your course, and you are responsible, and this is how we deal when we are responsible. We fill in the gaps. But that was very interesting. It's session very, very, very nice. I'm lucky that I'm attending with you. I'm learning from both of you, you and Ashley, and that session was very, very informative. Thank you very much.